Good. Did you just get back from the hospital?
Yeah, actually, I was a little longer there today. How are you doing? Okay.
We're good. This is the GO staff. Everybody. So we have our entire team here, and they're super excited to talk to you and hear about the amazing work that you're doing at Family Care Clinic. So I just thought that you might start with just telling them a little bit about your background and how you got started doing the work with Family Care Clinic. So we'll start there.
Hi, Samira. I just want to say hi. I'm here. How are you? Oh, we can't hear you. You're on mute. You're suddenly muted. There you are.
Hi, Scott. How are you?
Salama za kwako.
Wow. You still remember Swahili?
Kabisa.
Okay.
Nice to see you.
Same here.
So yeah, the staff's excited to learn more about you, and they haven't had the pleasure that I have to spend time with you. So they'd love to hear more about you and your work.
Okay. So hi, everybody. So my name is Dr. Samira Osman, and I'm the medical director, Family Care Clinic and the Youth Zone. So a little about the work that we do at these clinics. So we look after children who are infected with HIV. And as we all know that several years ago, HIV was deemed to be a death sentence, basically. So way back in 2001, that's exactly about 20 years ago, at that time, most of the children who are living in the West could access care for HIV quite comfortably, and survival rate was quite good. Whereas in our part of the world, especially in Kenya, we had absolutely no children receiving HIV care at that time. And it was believed basically that these children would not make it. So it was considered like not a worthy investment, as opposed to maybe looking after other children with other diseases, or, you know, investing the same limited resources that were there into other things for the people. However, at that time, our founder, who is Dr. Shafiq Isaji, he hails actually from Kenya, from Mombasa. So he, like myself, was also born here in Mombasa, which is a coastal city. I'm sure most of you can Google it out and see it's a beautiful place. It's an island actually, surrounded by water on almost all sides. And it connects to some of the most beautiful beaches in the world. Diani Beach is called. So Dr. Shafiq who is originally from Mombasa. He was at that time a lecturer at New York University, and they were looking into how they could support other countries that would want to start such projects where they would want to deal with children. And you can imagine the challenge that he set himself out to, because at that time, Kenya itself was not ready to provide HIV care to such children. So ours was a pioneer clinic that was set up at that time in the whole of East Africa, I believe. This was the first clinic that officially started offering HIV care to children. And the amazing thing is that some of those children who actually registered at that time, out of those, we still have a few that are with us at the clinic still. And most of them went on to become parents as well to children who are HIV negative, you know. So the beauty is that he gave them a chance to live when nobody else thought that they would ever make it. Yeah. And that itself is so touching, because you know, when a child is born and the child is actually exposed to HIV, because the mother is mostly HIV positive, then what happens is that there is a high chance that the child can be HIV positive if especially the mother has not yet been started on medication and does not receive what we call PMTCT, which is prevention of mother to child transmission medications. So basically, there is only a 50% of such a child making it to the first birthday. And 25% of these children will die, like 50% will survive up to their first birthday, and only 25%, a quarter, 1 in 4, will make it to see their second birthday. So you see, there's a very, very minimal chance that these children basically had at survival. However, when the clinic was initially set up, so what Dr. Shafiq set out to do was humongous actually. The drugs were not available in Kenya. You know, pediatric formulations are so different because we have to calculate the dosage of the drugs depending on the weight of the child. So if I have 10 children who are at the clinic, they might all be of different weights, and I'll have to be giving them different doses of the same drug. And secondly, most of these were coming in syrup forms at that time because, again, into the market, people were not yet aware on how else these drugs could be delivered to children. So it was very hard. Some of them, you required refrigerators to store them, and our people would not be able to afford such things. So it was a big, big challenge. And it is only later in the year 2004 when Kenya now adopted to start giving HIV care to children. So our clinic started doing that 3 years before the country itself did. And most of the time, our model that was utilized is considered as the Mombasa model of delivery of a medication to the pediatric population. So Dr. Shafiq, in his wisdom, understood that having a standalone clinic that would be able to suffice the needs of these children, who, remember, would be chronically ill at some point in time, would be very, very difficult if we had like a standalone center. You know, I mean, supplying all the equipment that would be required there would be very, very difficult. So what he did was he leveraged upon a private partnership. So within the grounds of General Hospital, which is our largest referral hospital in the coastal region of Kenya. So this particular hospital serves, like Mombasa has roughly about a population of about 1.5 million people. And then the environs around another 1.5 people. So Coast General Hospital serves about 3 to 5 million people. And our population in comparison, I'll tell you, is about 45 to 47 million people. So the entire, like almost an eighth of the population is served by this particular referral hospital. And he set up the pediatric HIV clinic within the hospital. So as part of the pediatric outpatient unit, he set it up there, looking into it in this way that the clinical staff would be provided by the hospital. So the clinical expertise would be borrowed from the hospital and the nurse, the doctors. He would add and support the administrative staff. So the model worked in favor of these children because, you see, what happens in a government hospital is we do not have a lot of staff who are dedicated to doing like follow-ups, who are doing home visits, who are able to support these children in other ways other than the medical bit. You know, staff most of the time in a public setting are always stretched to their limits. Yeah, so the staff is few, the work is a lot, and the quality of work that you end up delivering is not always the same then. Because obviously, if you're supposed to serve more people than you can, you have so many patients waiting, then it's a matter of trying to clear the queue rather than addressing the quality of that particular consultation that you're having. So time came when he realized this, and he put up staff that would be like patient advocates, that would work with the families and try to understand them. You know, it's so unfortunate that that time when the HIV epidemic was in its prime, most of those children were actually orphans. So they would be born, and sooner or later they would lose either one or both of their parents. So they had their grandparents look after them. Most of them of those grandparents were not educated. So getting across to them to make them understand the importance of taking HIV drugs regularly and consistently. Because with HIV care, we all need to understand that when somebody starts taking medication, they're taking that for life. You know, I always ask myself, I'm a medic, and I don't think I've ever, I shouldn't be disclosing this, completed like a full medication dose when I've gotten an antibiotic. You know, most of us do that, don't we? As soon as we think that 3 days are over or four, and then you're so tired of taking those medications. So I set myself in that same shoe, and I'm like, these children are taking them for life. And most of them actually are drugs that cause a lot of side effects, especially the former drugs used to have a lot of side effects. Like some used to cause intense nausea. So imagine what that does to you, you know, even when you feel like eating and you're really nauseated all the time. And then the sad bit is that some of these drugs have to be taken exactly at the same time. So you imagine trying to fit into drugs that you're taking like two. That time we had some that were taken 3 times a day, but basically 8 hourly. So if you're trying to put an 8 hourly schedule on a child, if you're giving them at 8 a.m. in the morning, let's say, the next will be 4 p.m. and the other dose will be at midnight. So do you wake a child up from sleep to give it to them? You know, I mean, the challenges were just humongous. Together with the fact that most of our clientele, of course, is very, very poor even up to now. That is why it's very important for them to understand the logic behind taking these drugs, behind why it is important for their health to be able to bring their viral loads to a level such that their body can function in a relatively normal way. And of course, in the last 20 years, we have come a long, long way, because you can imagine if a child was like 5 years old at the time they enrolled, 20 years later, some of them are like 25, are looking to set up their own families, are looking to have their own jobs. So again, adolescence came with its own challenges, because now this was a set of children who were looking to fit into a society, into a community where they were different. You know, adolescence is such a time when everybody is looking to belong. And these children, unfortunately, were found being rejected from all sides, because psychologically, we really didn't know how to prepare them for such challenges, because most of them we knew had been infected since they were babies. So they had been born with this infection, you know, through no fault of their own, through no mistake of their own. And I really, really felt, I still feel bad about it when anybody judges such children for something or for some action that they are absolutely not responsible for. So it hurts you, you know, when people, like there's this one incident that had come to our attention. There was this one young girl. That time she was about 18, and she was seated in a queue where the adults were also acquiring treatment. So basically, our cutoff used to be 18 at the pediatric clinic. Then they would graduate to the adult clinic. And she was seated there, and she actually heard or overheard one of the women uh, pinpoint to another one and say, what is this young girl up to? How come she's here in the queue, you know? So she overheard that, and she came back to us to tell us that, you know, why are you putting us among adults where we are being judged for being there, just for being there, you know, because somebody was looking at her with eyes that, how can you have acquired HIV at this young age? Not knowing actually that she was probably infected, of course, from birth. I don't even feel it's right to judge anybody for that matter who has HIV, because There was another time actually when I was working at the hospital in my initial years. You won't believe we had 33 patients in our ward at that time, in our female ward. And when we did testing for all of them, because it was protocol by the government to test all our people who are admitted, since you see, that's the time when you can best get as many people to get tested, of course, with consent. You won't believe 33 of those women, out of the 33 women, 30 of them were positive. 30 of them were positive, and not because some of them, they had absolutely no idea about their status. Some of them like literally cried and swore and said that I have never had a relationship outside my marriage. You know, I've always been faithful in my relationship. So they were also victims of circumstances whereby probably their husband was the one who had another relationship outside their marriage and who had introduced HIV into their particular circle. So these are challenges that we had to deal with, you know. And that is the time when we came up with the idea. This was in 2014, 2015 there, that we need to set up specific services for the adolescents, because as our clinic grew, as they grew, our needs grew, because now we were dealing with a set of individuals who were absolutely, we had no clue on their needs, and neither did they themselves. So you can imagine the background where we came from, that we really didn't know what we needed to give them, and they themselves also didn't know what they had a right over. So
Dr.
we came
Samira,
up with,
sorry, that's when Go Campaign kind of met you at this junction where you're thinking about adolescents and how do you treat them. And so I'd love to have you share with the staff at this juncture, you know, what the Go play in helping you.
exactly.
Yes.
So at this juncture, actually, when we were thinking about what to do, is when we first came across Go Campaign. And this happened because way back in 2006, the foundation that's called Keep a Child Alive, that was set up by Alicia Keys actually, was the one that started then supporting the clinic. So now this became a little more easier for Dr. Shafiq, because otherwise he was outsourcing funds on his own as an individual and getting people to donate towards this cause. So in 2014, when we realized the need for these children to have specific adolescent services, again, within the environment of the hospital, we had a place that was allocated to us. But now this was actually the home of one of our staff. So they had been allocated this particular space for years. And sincerely, the first time when I saw that place, I was like, no way, how will this be our center? You know, because this was basically a 2-bedroomed apartment that had been totally run down, and we just didn't imagine how that would be possible. So, of course, to do such a thing, you need a lot of financing. And Keep a Child Alive at that time, they introduced us to Go Campaign, and I think one of the directors there knew Scott personally, so he got in touch. And when they heard about the story and what we were setting out to do, we were so grateful for that time actually that Go Campaign supported us in setting that place up. So we had one particular donor who was willing to refurbish the whole place. But even if you have like 4 empty walls, what are you going to do with them if you're not able to equip them, to service them, to have people run them? So we were very lucky, I believe, that our project was one of them that was chosen to be supported by Go Campaign. And we came up with a model whereby we wanted to empower our own young people, those whom we had been seeing and who had grown with us, had been at the clinic, infected with HIV, to be able to support other people like themselves. So we came up with a program whereby we trained our young people to become supporters, what we call peer supporters. And you know, nobody understands you better than somebody who's already going through this particular illness or through this particular phase in life, right? So you will always feel more connected when you're having a similar situation to the person you're talking to. So employing this particular model really changed things. So we had our own young people, they underwent a formalized training, what we call a peer educators training. And they learned a lot of skills. Together we had some practical sessions, a lot of theory work as well, whereby they were now empowered to be able to support other young people adhere to their medication, understand the effects if they lost out on missing, like if they missed out their drugs, on how they could hold conversations with other people who were not HIV positive and talk to them about their status, to open up and disclose to their friends. You know how isolated you can feel as a young person. Imagine if like you're in a boarding school and you have nobody to turn to because you're HIV positive. Every time you go to take your drugs, somebody looks down upon you thinking that, oh, look, he's positive. You know, there's a lot of stigma still around this particular illness, which is unfortunate. But we tried to break through all these barriers. And it is again through your offices, the offices of Go Campaign, that we were able to furnish the whole place, to equip it with the best of everything that we required. And main thing is that to equip these young people who were initially just 6 in number, and then it kept growing. We now have more than 12 peer educators who are all trained in such a thing. And they receive a very minimal stipend of just $40 a month to be able to support other young people. So, you know, this, we are a huge, more of a family actually. And initially the name was Family Care Clinic for the pediatric one. So we left the Family Care Clinic where it was. And the criteria that we used to move them to the youth clinic would be anybody who's aware of their status. So mostly we start the disclosure process when they're about 10 years old. As they gradually come to understand, it's about 11, 12 when they really understand about their own diagnosis and they're willing to freely speak about it, is when now, when they are comfortable, the parents are comfortable, we move them to the youth clinic so that they can be among their own peers. And I have been personally working at the clinic from 2009. So this is basically like my 12th year that I'm working with a clinic at the same place. And yes, some people tell me, don't you get bored with the work you do? I'm like, every day is a blessing, because every day that you get to see the same children who you thought never had a chance in life, and they've now grown into young men and women who are taller than me, most of them. So it really gives you a sense of, how can I say, it gives you, you know, it opens your eyes to a world that sometimes it's not us who do things, but it's people like you who support such things. And when Michelle talked to me that she wanted me to talk to you people about the project that we have, I was very enthusiastic, because I was actually only scared that I'll put you guys to sleep, because I love talking about this thing. And I was really worried that, you know, I'll take up a lot of your time. In fact, I haven't even asked her how long I have to speak for. So yeah.
No, I think everybody's enjoying learning about your work. I'd like to kind of transition into COVID and, you know, the current situation with the pandemic and how that's impacted your work at the pediatric clinic and the youth zone.
Yeah, so basically when COVID happened, my biggest scare was for our young people who are already infected with HIV, because as you all know, what started spreading that is going to be riskier for those who have like already a compromised immune system. And things didn't look too good on our side actually at that time. Pretty far that Africa would be more of a deathbed, that there would hardly be any people able to survive. I mean, it was actually crazy. We really didn't know what we were getting ourselves into at that time. I mean, none of us knew, you know. and none of us could predict what was going to happen. So of course, what we started doing actually at that time, this was way back when our first case in Kenya was reported in March. That's like exactly a year ago. And we, through a team of other colleagues who are also in the public health department like myself, we quickly realized that one way in which we could save most of our people would be if we encourage everybody to wear masks, because that is one way in which we could prevent the spread. So funny enough, that time supply of masks was like, there was no supply of masks. I remember speaking to Michelle and she told me if there's any way Go campaign could support us. I'm like, we require this stuff. Michelle, you remember, I had actually told you that we require masks and sanitizers and stuff, but we can't purchase them. There's no way we can go to get them. I mean, a box of masks that used to go for like 25, about $30, was selling for nearly $500. Can you imagine? Like, they had hiked up the prices of those things that they were untouchable. And I really didn't see how we would be able to support them. So we came up with this, at that time, I still think of it as a crazy idea, but I seriously, I'm thankful for some of those things that we do. Kenya is a country where we have done away with plastics, yeah? So we do not use any plastic packaging and bags and stuff. It's totally banned. So this happened like, I think about 3 or 4 years ago. And what they introduced in place of plastics is non-woven bags. So what a non-woven bag looks like, I think is like your typical or non-typical shopping bag. That's a little soft, harder than tissue paper, but it does not contain plastic basically. So it is very firmly packed molecules. I don't know if most of you understand what I mean. I had one, I could show it to you. So this particular thing is basically like the disposable mask that we use, only a little thicker, yeah, because it's meant to be able to be durable. The masks that we use, the surgical ones, are also made out of non-woven fabric, but that one's it's fine. This one's a little thicker, so it's a little harder, or you can say heavier. So what we did was we repurposed these bags to be able to make masks out of them. And we did it at the clinic together with the young people. I managed to come up with a way in which we could use the bag, cut out thin strips to make like ties for the mask, and staple those things in place. So it was a very basic thing, but it worked because it was something that would be able to prevent the spread to the young people within the clinic as they waited for services, and of course to the staff as well. So whoever came in without a mask, that time in Kenya, masks were not yet mandatory. But we made it a point that whoever does come to the clinic and does not have a mask to wear, we would give them one. And we put up hand washing points outside the clinic. We started monitoring temperatures, and we started giving them drugs for longer because we were also in a lockdown situation. And the last thing that I wanted was any of our children to miss their drugs. So we gave them, like we usually give them monthly or 2 monthly appointments, depending on how a child is doing. But now we started giving them at least a 3-month supply so that they would not have to, run around looking for their drugs just in case they were not allowed to travel as yet between their home and the hospital. So that helped a lot actually. And we really struggled trying to bring in measures across the board into the clinic. However, unfortunately, 5 of us actually in the month of October, we all came down with COVID. One of our colleagues unfortunately lost her mom because of COVID, and later she tested positive. One of our colleagues was very sick. He had to get admitted. Luckily for me, I didn't have the typical symptoms of the cough, fever, but I had very intense chest pains. I had diarrhea, and I was generally feeling very weak. So I was managed at home, thankfully. I did not require hospitalization. But a colleague of mine who is younger, way younger than me, he developed severe respiratory distress. He had to be hospitalized, and Yeah, we struggled through this period, yes, but services at the clinic continued. We had the other staff who were not infected. There was some time we had to close the clinic for about 2 weeks, but after that, after everybody was tested and they were found to be okay, then we managed to continue the services at the clinic.
Well,
Just a minute.
Dr. Samira, I want to give space to the staff to be able to ask questions and for you to get to know them. So I'm going to throw it out. This is really was for the staff to get to learn about your work. So does anybody, Lauren, you're always good at starting. So put you on the spot.
What are you saying? I mean, first, I just wanted to say, Dr. Samira, thank you so much for sharing with us this morning. And I guess my question would be, you know, looking forward, what is it that, you know, how can Go Campaign continue to support you? You know, just listening to your story right now, I'm so excited to, you know, take some of your words and turn it around to, once again, like continue highlighting the work that you're doing for children. But I guess my question would be, you know, using our platform, what would it be that you would most like us to share about your work? Or something that you feel, you know, people might not realize, but really is the most important part of what you do?
Okay, so basically what I feel we need to actually let other people know is the fact that it's all about yourself at the end of the day. Yeah. So like one of our famous runners commented, you must all know about Eliud Kipchoge, who ran the marathon within the time limit of like less than 2 hours, and he made it. That no human is limited, you know. So what we instill in our young people as well is the fact that you can reach anywhere that you want, absolutely. We have had young people whose talent we have thankfully discovered through the youth clinic. There's one young guy we discovered, he used to come and sit at the clinic and be...
Sorry. Move the cars, both of them?
He used to be...
Just the one in front?
Gina, you're not on mute.
So
Sorry.
he used to come and be drawing, you know, with a pencil. He used to come and sit and draw very interesting pictures at the clinic. And one day when I had a look at his work, I'm like, did you do this with like a usual pencil? He's like, yeah. So we bought him some extra materials from the clinic, and he started his profession and he draws and paints quite a lot of pictures these days. And then he got into photography. So he's able to support his career through that, his family through that. So yes, it's all about trying to discover young people's talents, because I feel that one way or the other, all of us have a lot of value to add to life, and we can't be judged because of our HIV status. That is something that I always tell our young people, that don't think that this is like a death sentence. You know, none of us knows who's going to live longer. One of us can walk out of the hospital, you may be totally healthy, and you get knocked by a car and you die. So HIV is not something that will stop you at anything. And this is what most of those people who advocate for people who are infected with HIV say, that it shouldn't be looked upon as any form of disability or inability. It isn't, because this is just a condition. Once you learn how to live with it, you take your drugs on time. People have lived, in fact, for this matter, the thing in the HIV world now that we are seeing, the pandemic, is obesity. So you see, previously what happened was people who are infected with HIV used to be like judged because they were so thin, and nobody wanted to be like noticed, pinpointed and said that, oh, this guy has HIV because he's so emaciated. So these people, I think on the reverse, started feeding quite a bit, and some of the drugs also kind of had side effects of weight gain. And most of these people are actually now overweight. And now we're dealing with such problems, especially in the adult clinic, where we want to try and streamline their weights and, reduce the risks of diseases that are acquired as a result of obesity, like high blood pressure and diabetes and the rest. So yes, that's the paradigm that we have approached now. I hope I answered your question, Lorraine.
Yes, thank you.
Kristen?
Yeah, Dr. Samira, I just want to say, it's so funny when you mentioned you might put us to sleep. It was the exact opposite. I literally was like hanging on every word that you said. So I want to thank you so much. And you gave us a couple of anecdotes about specific children in the clinic. Is there any one story that sticks out to you over your years of working there that was a particular success story that you'd like to share?
I'm so sorry. I don't know if the rest of you could hear, but voice at my end was breaking totally, Kristen.
Oh, no, I'm sorry. I just was saying, is there any success story that you can share with us over your many years of working there that you'd like to share to shed a little bit of light on?
Yes, of course. There are several actually. So one success story that I would like actually, this is one young girl who started visiting our clinic when she was about 14 or 15 there. She had transferred in from another facility. And she was one of our peer educators as well. An amazing thing, she has gone on ahead to do psychology. She's now a psychologist, and she gives back to the clinic by volunteering her services at the clinic at absolutely no cost. So this is the type of work that, inspires you, that this is somebody who hardly gets anything else in life. And yet she's somebody who's willing to give so much back to the community and back to the clinic. She says that if it were not for the clinic, I really don't know where I would be. And the love and the services that you guys gave here made me what I am. It's unfortunate that currently she's going through a tough time. She went into renal failure because of, like you see, HIV induces nephropathy in some people. And over the last 2 years, she has been having very high creatinine levels. But since December, she's undergoing dialysis now. So yeah, I just want you all to remember her in your prayers. She's a gem of a soul, very hardworking. We have to force her these days not to come to the clinic because of her condition, but she still wants to give back so much more.
Danny, do you have a question?
I wanted to thank you so much for speaking with us. I think I'm echoing what everybody else is saying about how we were not bored whatsoever. And we're absolutely paying attention completely. We're so fascinated by everything that you're saying. I think I would like to know, I want to know a little bit more about you and what brought you to want to do this in the first place, to want to help these kids in the first place. Like, what spoke to you personally to want to be involved? Oh.
I'm so sorry, guys. As much as the perks of living in an African country are the beautiful beaches, our internet is absolutely lousy all the time.
That's okay. That's okay. I was just asking what brought you to do this work in the first place? Like, what inspired you? What spoke to you about wanting to work with these children?
So basically, I hail from Mombasa itself, but from a slightly remoter area away from the center of town. And I grew up basically on farm, which was very remote. And as a child, I remember that since our whole area, an entire you can say a few kilometers radius of that place, there was absolutely nobody who had any basically any car to drive them to the hospital or town. And we had a very lousy public support transport system that would be a bus that would work 3 or 4 times in a day. So this was like a place that's nearly about 20 kilometers away from town. And I know 20 kilometers in the US doesn't sound a lot, but this is big by our standards because Mombasa is relatively a very small island. So yeah, as I grew up, I always saw people. There was once I was about 10, and there's a girl who was like 4 or 5 who was brought with a snake bite on her leg. And her leg was actually almost as hard as stone when she was brought. So it happened in a very remote setting with like very far away from any sort of civilization. And the dad had actually carried her in her hands, bringing her all the way to our house, thinking that he would be able to get help there. And as my dad decided to drive the whatever, I actually saw the child breathe her last in the father's hands, So that was one experience that totally shattered me. And I was like, if I do grow up, I want to become a person who will be able to serve needy people and would be able to work to help save lives. So that is when I first decided that I did want to become a doctor. And ever since I started working at the government hospital, it's not like I didn't have opportunities to go out of it, but the work that I started doing, it kind of attached and grew on me that sometimes I feel it's an integral part of myself now. So yeah, those are the things that keep me going.
Thank you.
Gina, I think you had a question.
Oh, hi, Dr. Samira. I just want to say, I'm sorry, it's hard for me to turn my camera on right now. I'm in and out of internet, so I hope that you can hear me okay. But thank you for taking the time to speak with us. Just getting to see your face and directly hear your words helps us so much to be able to share your story with others. And we're so grateful for the work that you're doing. I would love to know, I know you've had tremendous success in boosting, the viral load suppression rate with children with HIV. And I'm just curious, what is it that you have found, how have you had that success? And do you have continued funding to continue that success? And so it's 3. How have you had success? Do you have the funding to continue that success? And then is there something else that you have found that you really need, or you're starting to discover that you need financial support to continue or to grow to help the children?
Well, to answer your first question, one of the things that has propelled this success, I believe, is the model that we use. And using peer educators has been one thing that has really assisted the system or the children in being able to suppress their viral loads, because they get to speak to like one of their own, somebody who also suffers from the same. And they tend to kind of have no barriers when they're speaking to their own peer educator. So that has largely, I feel, attributed to the success that we have had, where we have almost like 86% of our population of young people are virally suppressed. That's a huge number compared to the numbers that we have within our town itself, where we have only a 49% suppression rate among our young people. So ours is like more than 1.5 times what the county itself shows. The other thing is that where our funding is concerned, unfortunately, like I said, we had Keep a Child Alive that was supporting us with continuous funding. And that had to kind of was abruptly withdrawn because I think Keep a Child Alive had issues itself. They handed over us to another organization that's called United Purpose, which is actually based in Ireland. And these guys came over, they assessed the work that we do and were willing to continue supporting us. However, last year in July, they actually wrote to us saying that unfortunately, with the way things were going, the donor fatigue that exists, they would not be able to further support the work that we do. And we were in a state of frenzy on how are we going to continue supporting these young people. And backing out was not an option at all. So we had some buffer funding that had remained, which we have been using. And then luckily Go Campaign, of course, stepped in. I mean, this was absolutely like godsend, I would say, because we were really wondering how we were going to sustain ourselves as we look to establish ourselves as probably an NGO that would be able to fund. But then again, you see, putting up like an NGO would also mean increasing your staffing so that you have other people who are looking into such issues. I myself, like, you know, I'm a clinician by practice. I have my second degree in public health. That's my master's degree. And I'm full-time at the clinic because that is the work that I do. I do a lot of administrative work as well to support the clinic. But again, I would not be able to run like a whole NGO on my own, you know. So yes, we're very grateful to Go Campaign. And what we would like is if we could be assisted with probably ways in which we could support ourselves, you know, because at the end of the day, we all understand that unless you have self-sustaining organizations, it's very difficult to rely continuously on funding and donors. I mean, things have been so hard for everybody this past year, and COVID has actually taught us that things are very unpredictable in life. So we all have to have like a backup plan.
Mm-hmm. So I think it's very interesting that you're attributing this high suppression rate to peer counseling. Is that like mostly a, you know, obviously mental health is incredibly important. So being able to provide a resource for children, for them to talk openly and you know, get the support that they need, it sounds like that's what you're attributing to the success that you're having with their health.
Absolutely. I feel that peer educators have been an integral part of the success, together with the model of care that we have, where we offer flexibility to our young people to come to the clinic at hours that are suitable to them. We also offer services whereby if somebody cannot access their drugs, come and access them themselves. We would willingly offer to deliver them to their places so that they would not be affected. Like, you know, some students cannot get away from school because it's very hard to get an off and come to the clinic. So we would be able to accommodate that for them as well, especially for those students who are like candidates. Like we have our national exams that children sit for when they are in their class 8, that is about a 13 or a 14-year-old child. And again, 4 years later, when they're about 18 is when they sit for another exam, that's a national exam. So that whole year is quite an intense year of studying. And what we always do is we make sure that if they can't make it to the clinic, we make it very clear that we would be able to deliver their drugs to them so that they do not miss any of their doses. So yes, our program has ways in which we have tried to accommodate all these issues.
Wow. How many children are you currently working with?
So yes, we have a cohort of 740 children, and the bulk of them are actually the older population. So we have nearly 480 that are the young people who are at the youth clinic, and the rest are at the pediatric clinic.
Wow. And I'm just fascinated by you and the work and the incredible, help that you're providing to these children. And, so much has changed over the years with regards to medicine and the stigma of HIV. And is it with your program and with the medicine and the support that you're giving, are these children able to continue on well into their adult lives with leading, you know, with your support and the medicine, leading otherwise healthy lives?
I believe so, because you see, we've had so many success stories, especially where women who are HIV positive. So our clinic, one of the other things that we also did for many years was support pregnant women who were HIV positive throughout their pregnancy, and even after and during and after birth. So this was the PMTCT program that was also affiliated to the family care clinic in those years, up to a time in about 2015 is when the government thought that it was better if this was integrated in the usual maternal and child health package. So we have so many children who were born to HIV positive mothers, but who ended up turning negative after we had followed them up for a period of 2 years. Yeah. So this, really gives you hope that when you do the right things, when you're able to support them in the right manner, then you're able to have children who are HIV free. The same with some of our young women who have decided to have families of their own. We have a big number of young girls who are mothers now when they are in their 20s, and they've had children who are HIV negative. So those are some of the things that, yes, tell you that, when you're consistently and continuously doing something and being able to support them, the most important thing I feel is having a non-judgmental attitude towards the young people, especially because they're very, very sensitive lot. And we all know what it means living with an adolescent.
Mm-hmm. Mm-hmm. Right. And one last question, I promise. I feel like I could talk to you all day. Are the children who are HIV positive or born to HIV positive parents, are they a part of the same school system as all other children, or are they viewed differently by, by society there and forced to be, going to school in other places, or is there any segregation whatsoever? Are they fully integrated and accepted, just like any other child would be?
So basically, we have a non-discrimination policy in Kenya, and no child is supposed to be discriminated against, and they are supposed to be enrolled into the same schools that every other child goes to. However, during my time at the clinic, we've had complaints where, unfortunately, maybe a colleague or somebody would discover that or this particular parent's child is HIV positive, and they would bring issues. We brought it to the attention of the authorities because no school is allowed to do that. Every child has an equal right to the education, and no school is allowed to discriminate against an HIV positive child.
And do you get support from the authorities?
Yes, we do get well supported because, there's kind of a network to which we all belong, the HIV service providers. And I'm also a mentor and a trainer for HIV activities within our county. And I always bring it to the attention of the rightful authorities that this particular school at this particular whatever they're discriminating against. But of late, this was maybe 4 or 5 years ago when I last handled such a case. Of late, I've not had any such complaints, to tell you the truth.
It's wonderful to hear. Thank you so much.
My pleasure.
Sarah, Griffin, anyone else? I have a burning question. I know it's late for you, Dr. Samira, so I want to make sure you're able to get your dinner, but I want to make sure that our staff is able to answer you're here, get their questions answered.
I don't have another question, but I just wanted to thank you for being here because this was really insightful, and I'm just really grateful to have gotten to hear you speak. Thank you.
My pleasure.
I wanted to offer my gratitude to you as well. It's been an absolute pleasure listening to you. I've been involved with GO for many, many years, and I'm never short of wonder at all of the miracles it provides. Thank you.
Pleasure.
I have a very important question. I want to know if you've had any delicious candy lately. Mombasa has the most delicious selection of sweets you can imagine in all of the world. They're like, it's a spice zone, and they make the most interesting, yummy, delicious sweets and desserts, and it's like a candy land. Isn't that true, Doctor?
Yeah, and this is the home of baobab as well, if you remember. So Kenya supplies a lot of baobab, and these days there's a craze out there that it's the highest, it has the highest content of vitamin C, basically. So yeah, it comes flavored in all sorts of candy flavors now, Scott. We've really advanced since you last came over.
All right. Well, I look forward to tasting them on my next visit.
Definitely.
Thank you so much.
We're so grateful for your time and for everything that you shared with us, and just, you know, commend you for all the work that you're doing. You're literally saving children's lives. So thank you very much.
I think the pleasure is entirely mine that I finally get to see the faces behind all the hard work that do go campaign. And yes, I've had the pleasure of meeting Amy, Michelle, and Scott, and I really look forward to seeing the rest. Thank you for all the good work that you guys do. Keep it up. And may God always bless you, your families, and keep you all safe from COVID.
Same to
Thank
you.
you to you too.
Thank you, Dr. Samira.
Thank you.
Bye.
Bye-bye.
Bye.